So earlier I gave a presentation about the work that we've been doing with our colleagues in Tanzania on traumatic brain injury, and several years ago we, because of the collaboration, we started talking about doing similar work related to spine trauma, and what we do is essentially, we collect data, and that's a way to build a relationship with the hospital there, the team. Build trust, and then hopefully over time have an impact on outcome and management. And again, before I share with you the data, I want to put out a big thank you to our fellows and the local team on the ground in Tanzania. You see here on the picture some of the fellows that spent a year in Tanzania, from Andreas Leidinger from Barcelona. We have Beverly, who's actually from Kenya originally, but she's a neurosurgeon trained in London, and she's in Dar es Salaam now for a year. And then Scott Zuckerman, who is a neurosurgeon from Vanderbilt. I don't have a pointer here, I'm sorry. Oh, here. Scott Zuckerman, who is a neurosurgeon from Vanderbilt, who's spending 6 months in Tanzania. But he has been very, very instrumental in really pushing this protocol that I'll talk about forward. And then, of course, we have the local surgeons here, Dr. Shabani, Dr. Ruta, who run the neurosurgical unit at Moi in Tanzania. Now, again, Tanzania is a fast-growing country. The economy is booming. 58 million people. There are very few neurosurgical centers, and they're really all located primarily in the capital, in Dar es Salaam. Oh, there. Okay. So, and our program, I just want to put that in there because I think it is important to understand, and many people have an interest in global neurosurgery. We've been working together for more than 10 years, and how do you make a program work where, I go there once a year for a week, but obviously I work with other individuals, but how can you make sure that you have a lasting impact? So we go once a year as neurosurgeons from Cornell. We do a big neurotrauma course there. We operate, but we invite international faculty. I was just there last week or earlier this week, and we had a faculty of more than 20 doctors. So it's not only a Cornell program, but we really try to leverage the interest and the talent that's out there in terms of neurosurgical power force. We do a symposium, we do fellowships, so we invite surgeons from Tanzania to come to New York. And then we have, through patient funding, we have fellows that we fund that go to Tanzania for 1 year from North America. And that's really the glue, that's the key that keeps it all going. We decided to focus on clinical research, and that is primarily traumatic brain injury and spinal trauma. We have Skype calls every year, every week to communicate, and then finally we publish our results. So we're trying to use education and research to really have an impact, eventually, hopefully, on clinical management and outcome. These are pictures of some of our fellows. So what I'll talk about first is a database that we implemented several years ago, and that tries to keep track and describe the management of spinal trauma in Tanzania. This is a paper that summarizes a lot of that work. This was just published earlier this year in Journal of Neurosurgery. We included over 2 years, 180 spine trauma patients. As expected, a lot of them male and young age, and primarily falls and road traffic accidents. Dar es Salaam is in the de facto capital of Tanzania. And obviously, but the patients really came from all over Tanzania, and therefore the delay in transport. So some of those patients are really on the road for 10 days or 2 weeks almost before they reach the hospital. And our cutoff was 14 days. A lot of these patients, when they get admitted, they have complete spinal cord injury. At that point, they have ASIA A. We saw that, and again, this is an observational study. 40% of all patients, all comers, underwent surgery. The mean time to surgery was 33 days, okay? And there was no patient who had early surgery. And the time to surgery for patients with incomplete injuries was 36 days. For patients with complete injuries was 30 days. So patients with complete injuries actually went to the operating room earlier than those with incomplete injuries, which is also interesting. But what was really astonishing was that more than 20% of patients who underwent surgery improved in Asia grades by the time they were discharged, and that was significant. And the factors associated with improvement in neurological status were surgery. So patients who had surgery did better, and shorter time to surgery. We also looked at costs because we've very quickly realized that an important factor here in the decision-making process is really the cost of surgery, the cost of implants. So we took a very detailed look at the costs associated with the surgery, and we found an insurance status. And we found that patients with private insurance were more likely to have surgery than patients without insurance. And then if you look at the numbers listed here below that lists the costs, and doesn't sound very expensive, but if you consider that the monthly income of a lot of these patients is only maybe $70 or $80, then the costs are actually pretty significant. One pedicle screw is $69. The surgery, they have a flat fee for surgery that's between $100 and $700 depending on your insurance. A CT scan is about $70 to $90, and X-ray is $11, and so forth. So these things obviously add up. And if you can't afford it, if you can't afford the instrumentation, then there's no system in place that will cover those implants on an emergency basis, and that will hopefully change now. Mortality was about 10%. Obviously, there were complications, especially pressure ulcers, wound infection that were seen, but overall, the wound infection rate actually was not very high. Now, and then we decided to look at those two patient groups, the ones who had surgery and the ones that didn't have surgery, look at those separately to try to tease out what determines really that the patient has an operation. So this is looking now at the patients who had surgery. 97 patients underwent surgery, 23 cervical surgeries, 74 thoracolumbar instrumentation surgeries. These were all fusion surgeries, and the implants were donated by companies. We asked companies directly. There are always groups that come in from all over the place that bring instrumentation. So again, and some of those implants were bought by the families and came in that way. In terms of the surgical delays, here we're looking at the time from admission from injury to admission, which was actually in the surgical group was only 2 days, wasn't so bad. But then the big delay is really the time from admission until they have surgery. And the delay seems to be really primarily related to the fact that these patients or families have to generate the money to pay for the implants. That was really the main problem. That's how this delay of 20 to 30 days comes into play. So we also looked at the type of surgery. So if somebody has an operation, what type of surgery are they getting? Short segment fixation, obviously, because there are not that many screws available. And then some unorthodox surgical decision-making, probably. The construct ended in an injured level in 61%, or at a junctional level in 63%. However, that is something that you have to take into consideration. I mean, you have to do it because there's just not enough screws and plates and caps available. In terms of neurological improvement, that was seen in the surgical group in 17% of patients, and the single most important predictor of neurological improvement was shorter time to surgery. Each day taken earlier for surgery offered a 4% increased odds of neurological improvement. So I think these are, it's a single study, but it's not the great, but it is really interesting, and I think it's very important to point that out, that surgery really improves outcome. And then we looked at patients who didn't have surgery. So the non-operative cohort, 270 patients didn't have surgery. 145 out of 270 didn't have surgery. However, a lot of those, if you look at the indications or the instability, a lot of those had indications for surgery, 124. So 86% of those patients really should have had surgery because radiographically they had an unstable spinal injury. But they didn't have surgery because implants were not available. Then we looked at mortality, and there were a fair number of patients who died beyond 1 week, which was probably not related to the direct trauma. And we looked at the predictors of non-operative treatment. Patients who had cervical injury were more likely not to have surgery. So in summarizing these results, we saw that there was a real shortage of implants, and there was a lack of surgical training. There was a lack of really urgency when patients came in, especially with incomplete injuries, to take them to the operating room. They would prefer patients who had a complete injury over those who had incomplete. Sometimes I think also because the risks of that surgery were just lower, and we needed really more. I mean, there was really a big lack of a protocol. So what we did was we sat down with the Tanzanian surgeons, and we came up with a very simple spine trauma protocol. And the trauma protocol really prioritizes patients who have an incomplete injury. If you're neurologically intact or you have a complete injury, then there's no urgency to do an operation. But if you have an incomplete injury and you have a compressive lesion, you should have surgery within 72 hours after admission. That is the goal. And our fellow Scott Zuckerman, who's there currently, he, together with the local surgeons, it's really his goal and his job to implement this protocol. And it seems to work. We've been doing this now for 4 months, and he's been able to decrease the time to surgery to 1.8 days for patients with incomplete injuries. If you look here, days from admission to surgery, it used to be, based on our previous data, 24 days for all patients. Now it's 2.1 days for incomplete injuries, from 22 to 1.8. Now, these are preliminary data, and this only works because Scott is there. He's a fellow who's funded by us, because he's every day in the operating room, and he reminds the surgeons and the attending surgeons that, let's take this patient to the operating room. And it only works because the local surgeons, they really want to do it. They accommodate. So it is possible. So you can dramatically increase the number of surgeries that you do. And what helps, obviously, that we've got donations from companies. So these are some of the surgeries that were done. So, this is an ongoing study, but what we seem to be able to show is, time is spine. The sooner you operate, the better patients do in terms of their outcome. Non-operative treatment is associated with increased mortality. The cost issue is something that we can't really have an impact on. It's not sustainable just to send implants there and expect at the end of the day nobody really to pay for them. That's not going to work. So we got to work with the hospital, the insurance companies, government, and so forth, to come up with a system where emergency or urgent implants are being covered, and eventually by insurance companies probably as well. We saw some complications with those recent spine cases, especially in the ICU. Now, suddenly they're all having great surgery, and then they come to an ICU, and the ICU is overwhelmed, and then patients have a complication in the ICU, and that's something that we're watching very carefully. But that's something that certainly needs to be taken into consideration. So that said, I think I've told you enough. I think this is really exciting, and thank you for your interest and for your support.